Hey everyone, welcome. In this explainer, we're going to tackle some essential topics in pediatrics. But we're not just going to list facts, we're going to connect them, giving you a really powerful framework for your exams.
You know, if you've ever felt like you're just drowning in isolated facts, trying to memorize dozens of chapters, well, you are definitely not alone. The real key to mastering pediatrics isn't just memorization, it's seeing how everything connects. And that's exactly what we're going to do today. We're going to connect those dots.
So, here's our plan. We'll kick things off with the immune system. That's our foundation. Then, we'll see how immune issues can show up in places like the eyes and skin. After that, we'll get into solving some clinical puzzles, and we'll wrap up with some final, high-yield points for your exams.
All right, let's dive right in with our foundation, the inborn errors of immunity. Honestly, if you can get a good grip on these genetic conditions, it's a total game changer, because they explain so many of the bigger systemic problems we see in kids.
So what are these things really? Well, inborn errors of immunity, or IEIs, are basically inherited genetic disorders. Think of it this way. There's a specific defect right in the DNA, and that defect means a crucial part of the immune system is either just missing or it doesn't work right. And that, of course, leaves the child incredibly vulnerable.
Okay, this table is super helpful because it takes a really complex topic and breaks it down. We can basically classify these disorders based on which part of the immune army has a problem. Is it the T cells, the B cells, which make our antibodies? Is it the phagocytes, the cells that eat germs, or is it the complement system? Depending on where the defect is, you get a totally different pattern of clinical problems. Okay, let's start with the big one, the most severe, SCID. And when I say severe, I mean it. This is a true pediatric emergency. What's happening is that these babies have pretty much no functional T cell system. And if you think of the T cells as the generals of the immune army, you can see why that's so catastrophic. It leaves them wide open to really severe infections from things that honestly wouldn't bother a healthy kid at all. I'm talking about things like pneumocystis pneumonia or relentless candida infections.
Now with X-linked agammaglobulinemia, or XLA, it's a completely different story. The T cells are working just fine. The problem here is that the B cells, they just don't mature. And if you don't have mature B cells, guess what? You don't have antibodies. Now, the timing is a huge clue here. Infections usually kick in after 6 months of age. Why? Well, that's right around when the protective antibodies they got from mom start to fade away. And that's when they become vulnerable, especially to those encapsulated bacteria that really need antibodies to be tagged for destruction.
Okay, so we've talked about what's going wrong on the inside, but what's really fascinating is how these deep immune problems show up on the outside. It's not just about infections. A lot of times they present with really specific telltale signs that you can see, particularly in the skin and the eyes.
And Wiskott-Aldrich syndrome is the absolute classic example of this. You've got one single gene defect, but it causes this perfect classic triad of problems. You get eczema on the skin, you get thrombocytopenia, so low and really small platelets that lead to bleeding, and of course you get the recurrent infections from the immune defect itself. If you see that combination, eczema, bleeding, infections, your brain should immediately go to WAS.
Here's another great one that shows this integration: ataxia telangiectasia. I mean, the name itself gives you huge clues. You know it's an immune deficiency, but then you have ataxia. That's the neurological part, the problems with walking and balance. And telangiectasia, those are these tiny, little dilated blood vessels you can literally see, often in the conjunctiva of the eyes or on the skin.
Of course, to be able to spot these things, we need to know the basic language, right? The language of dermatology. So take a look at these two. They're both raised, solid lesions. The only thing that separates them is size. If it's small, less than ½ centimeter, we call it a papule. If it gets bigger than that, it's a nodule. It's really that simple.
Okay, now look really closely at this one. See how it's not just a random scratch or a line? It's this thin, kind of grayish, thread-like thing in the skin. This has a specific name. It's a burrow. And if you see this on a patient or on an exam question, what's the one diagnosis that should just pop into your head?
That's right, it's pathognomonic for scabies. And pathognomonic is a great word. It means that if you see this sign, it points directly to one specific diagnosis. And in this case, that burrow is literally the track left by the scabies mite as it tunnels under the skin. This is an absolute must-know sign.
All right, let's switch gears from the skin to the eyes. You know how when you take a photo with a flash, you sometimes get that red eye? That's the normal red reflex. But if you shine a light in a child's eye and you see this,
A white pupil, a white reflex, that's called leukocoria, and it is a massive red flag. This isn't something you watch. It requires immediate, urgent evaluation.
And here's the absolute bottom line, the critical take-home point. A white pupil in a child is retinoblastoma until proven otherwise. Retinoblastoma is a malignant tumor of the eye. You don't wait, you don't hesitate, this is an emergency.
Okay, so we've got the basic science, we've got the physical science. Now let's do the fun part, putting it all together. Because success on your exams isn't just about memorizing facts, right? It's about recognizing the patterns. So let's work through some of these classic clinical puzzles.
This slide right here, this is pure gold. It's all about connecting that one key clinical clue to the most likely diagnosis. For instance, you get a question about a baby whose umbilical cord took forever to fall off, and they get these bad infections, but there's no pus. Boom, leukocyte adhesion deficiency. Or how about a teenager with their second or third bout of Neisseria meningitis? You've got to be thinking about a late complement deficiency.
So here's a spot where a lot of people get tripped up, telling the difference between a B-cell defect and a T-cell defect. But there's a really simple way to think about it. Just look at the bug. B-cell problems where you don't have antibodies lead to infections with encapsulated bacteria. T-cell problems are much, much broader. You're going to see issues with viruses, fungi, protozoa, all those opportunistic infections. And like we talked about before, the timing, early infancy versus after 6 months, is another huge clue.
All right, we have covered a ton of information. But if you're doing some last-minute revision and you can only remember a few things, make it what's on these next slides. These are the absolute, can't-miss, high-yield takeaways. This one is a board exam classic. You will see this association over and over. Recurrent Neisseria infections. Why? Because those terminal complement components, C5 to C9, are absolutely critical for taking out Neisseria. So if a patient is missing them, they are uniquely, specifically vulnerable to that one type of bacteria.
And here's another one of those super unique clues from the patient's history. A delayed umbilical cord separation. Normally, for the cord to detach, you need healthy neutrophils to march into the area and do their job. But in leukocyte adhesion deficiency, LAD, the neutrophils can't get there. They're stuck. So if that cord is still hanging on after 30 days, you have to think LAD.
And yes, we're going to say this one more time, just because it is that important. This is not just a fact to memorize for an exam, this is a clinical imperative. A white pupillary reflex is a pediatric emergency. It could be the very first sign of a cancer that, if you miss it, could cost a child not just their sight, but their life.
So let's just do a super quick recap of our journey today. We started with that foundation, the inborn errors of immunity. From there, we saw how those core problems lead to really specific patterns of infection, and how they often show up with those telltale signs in the skin and eyes. And we learned that the real key to cracking these cases is to connect that one unique clue to the right diagnosis.
So, we've seen again and again how a single gene defect can link totally different body systems. But here's a final question to leave you with. Think about this. What single underlying cellular process could possibly connect a broken immune system, a progressive neurological disease, and a high risk for cancer all in the same person? It makes you realize that sometimes the answers lie at a much deeper level than just the organ systems we study.